So coming to the maxillary cancers, I am Dr. Amit Kesri, and Asim has already introduced me. So I will straightforward go to my presentation. So lecture overview is this, that we will discuss some relevant anatomy, workup and investigation. What are the different histologies we face in our day-to-day practice and approach to the management. So coming to the anatomy, we all know that it is a box. Maxillary sinus is the box separate structures, and superiorly we have orbit. Posteriorly we have the pterygopalatine and infratemporal fossa, and if we go medially we have the pterygoid process, and inferiorly we have the alveolar process. And there are a nerve, inferior orbital nerve, which is important, maybe sometime involved. If you go onto the medial side, we have the ethmoid sinus and the nasal cavity. So this is important, and once we remove it, then posteriorly we have choana, where the tumors go or into the pterygoid muscles. So this is the confines, beyond the confines of the maxillary sinus, just for the revision. Then coming to the maxillary sinus revision with the orbit, we have to understand that in the orbit, the two walls which are intermingled with the maxillary sinus is the inferior and the medial wall. And in the inferior and medial wall, the orbital periosteum is the first structure. So the first structure, orbital periosteum, is a tough barrier for malignancies from maxillary sinus to go into the orbit. But if that is breached, then the next layer is fat, and after that the muscles comes. So it is important that when you are planning your maxillary sinus, you see that what is the involvement of orbit. And for orbit, the MRI is the better investigations. Coming to the bony anatomy, we all know that there is a orbital fissure, superior and inferior, greater and lesser wing of sphenoid. And then on the medial wall, we have the lamina papyracea, and again the orbital periosteum, which needs to be very, very important for our management. So maxillary sinus cancer usually present between age group 4 to 6 decade, but yes, some of the pediatric tumors present early, especially the rhabdomyosarcomas. And early cancer confined to maxilla usually have minimal or no symptom. That's why the patient, when present to us, would have a extensive disease, mainly T3, T4 disease. T1, T2 diseases are very less. It can cause nasal symptom depending upon the extension, alveolar process, dental, orbital symptom, and intracranial symptoms if it goes through the pterygoid or through the one of the fossa, like foramen ovale and other areas into the intracranial. Nodal stress is less common, but if it is there, then it is level 2 and submandibular lymph nodes. And metastasis is rare, but yes, it has to be kept in mind in extensive disease, and especially adenoid cystic carcinoma and other malignancies. So if it goes into the nasal cavity, usual nasal symptom, we all know medullary fusion is important, precision tube blockage. And if it goes to the intracranial fossa, it may have some intracranial symptom. In the maxillary sinus, it may present as mass, ulceration of skin, paresthesia, trismus and pain, loosening of teeth, or some ulcers in the hard palate. In the ethmoid sinus, we have already discussed about the orbital symptom, proptosis, chemosis, and visual loss because of the close proximity to the orbit. Coming to the clinical examination and workup, it starts with the inspection. So you have to inspect the skin over the maxillary sinus. What is the status? It is color is the same, or there is a color change. You have to pinch the skin with the maxillary sinus tumor, that the skin is pinchable or it is freely mobile over it. The orbital examination is very important, especially regarding proptosis or any chemosis or any the movement of the recti muscle, like medial rectus involvement is quite common, and the inferior rectus if there is an orbital extension. Oral cavity examination is very important. You have to see the hard palate. You have to see the alveolar process, the upper gingivobuccal sulcus, because these all areas can have the extension of the maxillary sinus tumor. Nasal endoscopy is important to know that what is the status of medial wall or the middle turbinate or the ethmoid sinuses. Biopsy is an important investigation, but if there is a suspicion of malignancy and if radiology is not done, the radiology should be done first before the biopsy. We'll talk about the biopsy, which is the most important investigation, and it is vital for both management and the prognostication of the disease to the patient, depending upon what kind of biopsy it is. Histopathological diagnosis also aid in selection of treatment, that what kind of treatment, although the maxillary sinus, the primary treatment is the surgery, but sometimes neoadjuvant therapy. Hello? Am I audible? Sorry.
Yeah, please continue. I think there are some disturbances.
Okay. So the important point is a negative biopsy does not rule out the diagnosis. Many a time, if the biopsy is done from the nasal cavity and it has lined mucosa or the secondary changes happen, then it should be repeated before stamping it as to be a benign disease. And deep endoscopic biopsy from maxillary interim is a good diagnostic yield. What we do that we see the radiology and the enhancing part, which is enhancing the tumor part, we try to take the biopsy from that area. And if after 2 biopsy has not been enough, you can do intra frozen or squash cytology to see. And also keep in mind the invasive fungal infection, they usually mimic malignancies. The only thing is that the patients are a little bit younger, very well preserved even in advance. We will see the case example as we come along. Coming to the radiology, if it is limited to the maxilla, we can get away with the CT scan if there is no orbital involvement. Like in this case, it is a tumor is mainly into the confine of the maxilla. It is involving the inferior orbital wall, but is not going into the orbit. But the inferior wall of the maxilla, that is the alveolar process, is involved, and there may be a swelling intraoral bulge also. This is adenoid cystic carcinoma, but the tumor is involving the orbit, and if it is there is no good planes, and then MRI is very useful investigation to see the real extent of disease into the orbit. Is it only the periorbita or the muscles are involved, or the dura less than 5 millimeter of extension to the dura, then there may be the dural involvement. And although in dural involvement in maxillary sinus is in the very latest stages, but yes, it's do sometime involve the maxillary cancers. So like this is a case of a maxillary. Here you can see that there is some skin swelling. We can see that there is an ulcer on the upper alveolus. And if we see the CT scan, in CT scan, we need to require both soft tissue and bone window, because bone window is show the bony erosion. So we have, you can see that the subtle bony erosion here, if you compare from the right side and the left side, and there is a soft tissue swelling here. So this is all, the maxilla may seem pretty not well. So it is basically arising from this alveolus, but involving the maxillary sinus and going on the periosteum, following the periosteum of the interior wall. So you have to examine the patient fully, and a nasal endoscopic examination adds to the diagnosis. The patient, we can see that had no proptosis, no chemosis, but that may sometime be involved. So this is another case. You can see that the tumor, the maxillary sinus is, the wall is eroded, the inferior orbital wall is eroded, and this is inside the maxillary sinus. With erosion of the walls, and there is some extension into the ethmoid sinuses. So according to the symptom, sign, and radiology, you have to consider. And again, this is a recurrent case. This is a very extensive case, recurrent adenoid cystic carcinoma. So you can say apart from the maxilla, the orbit is involved, even the dura is involved, and more than 5 millimeter of involvement is there. Skull base is involved, pterygoids are involved, and then it is going into the cavernous sinus. This is adenoid cystic carcinoma. Here you have to see if you really can operate with a good margins. The other thing is that sometimes the tumor look malignant, but repeated biopsy, if it is showing that 2 biopsies, and then we go ahead with surgery. Otherwise, we try to for a tissue diagnosis. So this was a case of infected AC polyp, which looked like a malignancy. And it was referred as a malignant case, but it was an infected AC polyp, which we could identify. And then, although we did an oncological surgery, in this case, we removed the entire wrinkles and everything was cleared. But the intraoperable also was of a benign tumor, no malignant cells present. Then comes some case which may stump it. So here we can also do, we can see there is a lot of skin involvement. So what we do is now we are following is that we do FNSE investigation, FNSE as investigation before taking a biopsy. And the FNSE has proven that this is a invasive aspergillosis, which is quite common in this part of North India, especially Punjab and UP, all agricultural belt areas, Haryana. Invasive aspergillosis in immunocompetent patient. So sometime the patient has to be, the tissue diagnosis is very, very important. And if it is coming to skin and sublabial area, FNSE is also a good investigation before you undergo a biopsy if the yield is negative. So most frequently involved is maxillary sinus and nasal cavity. Most common types are squamous cell carcinomas. Sinus undifferentiated carcinoma usually involve the nasal cavity, but they also sometimes involve the maxillary sinus. The others are adenoidocystic carcinoma. Classification, I will not go into details. I will just touch upon the TNM classification, which is really important. So TX is the primary tumor which cannot be assessed. So we have to find out that which area is the tumor is, and it is the T4A and T4B. Till here we can operate easily with modern. Here we may need extended maxillectomy to remove the areas from the pterygoid till the pterygoids and the ethmoid sinus. But these are the area where you have to see that this may be the extensive, and do we give any neoadjuvant therapy before we operate? Because if you have margins positive tumor, then there is no point operating. And sometimes we may have to do the craniofacial resection for these cases, especially T4A and T4B. This is the histological, different histologies. There are many histologies which are there in the malignant, but the squamous cell carcinoma, adenoid cystic carcinoma, and adenocarcinoma are important from the maxillary point of view. And the other is we see rhabdomyosarcoma, chondrosarcoma. Leiomyosarcoma is again rare. So these are the tumors that which we encounter in our daily practice. Squamous cell carcinoma by far is most common, and degree of differentiation determine the treatment well to moderately differentiated surgical and medical oncological treatment. Poorly undifferentiated, if lot of extension to skull base and dura and orbital involvement, then you can consider regarding chemoradiation. And it is poorly undifferentiated with extensive or even without nodal metastasis have poor prognosis. And the other poor prognosis is the bilateral cervical node metastasis. So this is a typical squamous cell carcinoma with eroding the interior wall and the medial wall. The septum may be preserved here, but the posterior wall, there is erosion of the part of the posterior wall. And this is the pterygoid, and here the tumor is going almost to the pterygoids. So if we remove here from maxillectomy, we might need to drill the pterygoid completely to posterior part of the tumor. The other issue with squamous cell carcinoma is that inverted papilloma, when there is a recurrent and there is a lot of bony erosion, then you suspect and you send multiple tissues for biopsy, because many have the part of it goes into the debrider. So you have to be very careful that on the enhancing area, you have to send for biopsy. And if it is, if you are able to remove it completely, you can observe patient, or sometimes the radiotherapy needs to be given. Adenoid cystic carcinoma is the most common type after SCC. Maxillary sinus and nasal cavity are one. It consists of 3 different subhistologies like tubular, cribriform, and solid. Neural spread is very, very common to the inferior orbital nerve. and cavernous sinus is commonly involved, and extension to cavernous sinus must be ruled in adenoid carcinoma. Otherwise, within a matter of 2 or 3 months, the tumor may involve the cavernous sinus. And angio invasion is also so with adenoid cystic carcinoma. Recurrence at local size and distant sites are common within 3 years, like the case I have shown with extensive orbit and skull base involvement, including the cavernous sinus. Adenocarcinoma is the third most common cancer. Mainly involve the nasal cavity, but involve the medial maxillary wall. There are salivary and non-salivary types. Non-salivary are further classified into intestinal and non-intestinal. The sinonasal intestinal type occur in woodworkers. We typically see the carpenters presenting to us with sinonasal mass, usually in the nasal cavity, but sometimes the medial wall is involved of the maxilla. And sinonasal ITC are mostly low grade, but sometimes high grade is there, and which is a little poor prognosis than compared to the low grade. Rhabdomyosarcoma is in pediatric and young adults. The differential diagnosis sometimes is juvenile nasopharyngeal angiofibroma. The only difference is the contrast enhancement and the widening of the spinopeltine foramen are a little different. This is also slow growing and vascular lesion, and it has different variety. Embryonal variety is more common in the pediatric, alveolar, pleomorphic, and spindle cell types. So rare histology are sinonasal undifferentiated carcinomas, lymphoma, malignant melanoma, and chondrous sarcoma. So these are less commonly seen in the maxillary sinus, but yes, at the high volume center, you see cases. So just few of the examples. This is sinonasal undifferentiated carcinoma involving the part of the orbit with intraorbital and this. So here it combined tumor board discussion is done. I will come to it. And then again, this is a adenocarcinoma, extensive one involving the orbit ends. So approach to the management, this is my final thing, is the biopsy extent of tumor. Discussion in multidisciplinary tumor board with oncology team and radiology and the surgery team and possibly a radiologist is a very good. Surgery is the mainstay of management, excision with margin in block, which is for most of the squamous cell carcinomas. Neoadjuvant therapy is given for margin to get good margins around skull base, orbit, and minimal in skin involvement. Post-op chemoradiotherapy is usually needed. So the flow chart is that you do endoscopy and imaging, and then after imaging, you do a biopsy. I think I've already talked about it. And then depending upon the tumor board and the histology, everything is decided that the patient will go in which arm, and there is switching over to the other arm, depending upon the extent. So my surgical tips is that I cannot stress more than that, is the combined treatment planning with tumor board. Open surgery is better suited for maxillary sinus cancer. Endoscopic surgery is only possible in limited medial and interior wall involvement. Go one layer more than the involved structures. Involved ones should always be drilled because the radiation therapy did not work on the involvement. Debulking the tumor, if you are doing an endoscopic approach, to clear the choana first to avoid choanal venting effect, so that the bleeding goes into the nasal cavity, although it does not apply to the open approaches. So endoscopic surgery has very limited role in the maxillary sinus cancers, and only medial wall of the maxilla can be very well removed. If the rest of the walls are involved, the open surgery suits better. And the partial surgery is like partial maxillectomy, which may be inferior partial maxillectomy or the medial maxillectomy. Total maxillectomy is the surgery which we do for the squamous cell carcinomas most of the time, unless the inferior wall is completely free, which is less likely. And then Weber-Ferguson incision or the lateral anatomy, depending upon what is the extent. Extended maxillectomy means removal of tumor from the ethmoid sinuses and the pterygoid and the other sphenopalatine infratemporal fossa. Incision endoscopic is very limited. Mainly the workhorse is Weber-Ferguson. Sometimes mid-phase degloving, we also do mid-phase degloving for tumors. So this is a tumor which the radiology I have already seen that it is involving this. So we decided for the infrastructure maxillectomy in this case, and we were able to achieve that. The maxilla was removed, preserving the orbital wall as it was not involved. But again, after the removal of tumor, we removed the inferior orbital rim and then left the periosteum intact, because one layer more is always good. You get good margins. So this was the specimen which we could remove, and we always get a palatal obturator so that the patient are able to eat. In almost all the cases, we are able to get a palatal obturator, so that you don't have to put a sponge there, and the healing is better. The patient has good feel good factor after that. Again, total maxillectomy, so good flap, and you have to always palpate the flap for any involvement, and then take that area if there is an involved. Skin is always palpated, and the MRI is better investigation to see what kind of level is involved. And then you do a total maxillectomy. Pterygoid area has to be drilled with taken with the heavy gauze and then removed. You can use an orbital protector, or you can use a spoon if you do not have one in your OR. Just a small video to show that how we do the mid-phase degloving. So it is from this to this, but this has very limited. If the interior wall, we can do remove all the wall, but if one piece removal, then sometimes it is difficult with this. I'm just showing it just for the resident that intercartilage incision both side, and then the transfixation incision, and then you elevate. The entire midface can be elevated, and the entire maxilla is visible, and you can do this. Is for the benign tumor, so I will not go into the details of it. Then sometimes rare pathologies like this is a case of chondrosarcoma. Again, it has a soft tissue component, so we diagnose with the FNSC itself. Sometimes we may require a small biopsy, but many a time we are able to distinguish. So here we remove the tumor with our neurosurgery colleague, and then we did a wide craniotomy, removed the tumor entirely, and then a radiotherapy was given. This patient has tumor-free survival for 4 years, and then again operated, and then given radiotherapy. 7-year follow-up. This is a mesenchymal tumor. It was a low grade, so we went. It was mainly involving the ethmoid, and it's a slow-growing tumor. So we went for endoscopic approach. This is almost 5 years that patient was fine. Again, adenocarcinoma operated outside. Medial wall was involved, but the superior thing was left. And after this, we went ahead. There was dural involvement, so we resected the dura. And this is the post-op after the adjuvant therapy, almost 2-year post-op. Everything is fine. This is the dural repair which we have kept here. So with this, I will end my presentation. If there is any questions, we can take as we progress in the webinar.
Thank you, Dr. Amit. Thank you for such a wonderful, comprehensive and elaborate presentation, which included all the histologies and surgical approaches and management of maxillary tumors. Thank you. All the questions we'll address in the end of the session. Right now, I think we should move on to the case discussion. For case discussion, I would like to invite Dr. P. Arun. He is Senior Consultant, Head and Neck Surgery, Tata Memorial Center, Kolkata. Sir, are you there?
Hi.
Hi, sir.
Hello, sir, team. Are you able to?
Yes, sir, we are able to hear.
Yes. Great.
Then Dr. Ravi Meher, he is Director Professor, ENT and Head and Neck Surgery at Mahamana Azad Medical College, New Delhi.
Hello, sir.
Hi, doctor.
Hi, sir.
Ravi, how are you?
Yes, sir. Sir has been my teacher also. Welcome, sir.
Thank you for having me here.
Then I would like to invite Dr. Kaveri Kaketi, Associate Professor, Head and Neck Surgery, B. Balwa Cancer Institute, Guwahati. Dr. Kaveri.
Yeah, hi.
Hi. And then Dr. Hitesh, he's consultant head and neck surgery at Fortis Hospital, Mulund, Mumbai.
Hi, Dr. Ravi. Thank you for having me here.
Hi, Dr. Hitesh. Dr. Amit, we would also like you also to be on the panel for case discussion.
Sure.
Thank you. Now I would like to invite Dr. Kirti for the case discussion on maxillary sinus.
Please go ahead, Kirti.
Sure.
Good evening, everyone. My case for today is a 48-year-old female housewife presented with chief complaints of swelling in left cheek since 4 months and with ulceration and pus discharge for past 1 month. Left nasal obstruction was there for 3 months and left oral ulceration for 2 months. Patient was apparently well 4 months back when she noticed a swelling in left cheek, which was insidious in onset, gradually progressive in nature, initially a size of chickpea, but now has progressed to the present size, so much so that it involves the inner part of the left eye for past 1 month. There is also ulceration and pus discharge over the swelling since 1 month. Swelling was associated with pain, which was also insidious in onset, initially dull aching in character, gradually progressive, and patient complains of increased pain for past 1 month. History of left-sided nasal obstruction is there, which is also insidious in onset, progressive in nature, and has now progressed to completely obstruct the left side of the nasal cavity for past 1 month. Also, there is history of associated left nasal mass for 2 months, presently filling the entire left nose. History of left nasal discharge for 2 months, which is whitish in color, sticky in consistency, occasionally bloodstained, and no aggravating or relieving factors. And there is also history of decreased smell perception for past 1 month due to nasal mass. Patient complains of left-sided oral ulceration for past 2 months, which involves the upper teeth, associated with occasional bleeding from the oral mass and is associated with pain and tooth loosening. And there is history of left eye watery discharge since 1 month. No history of protrusion of eye, double vision or blurring of taste. No history of reduced mouth opening or restricted jaw movements. No history of any ear discharge, ear pain or decreased hearing. No history of mouth breathing or snoring, headache, vomiting or dizziness. No history of neck swelling or fever. No history suggestive of distant metastasis like cough, blood and sputum, abdominal pain or swelling or wound pains. No history of weight loss or decreased appetite. Coming to personal history.
Dr. Kirti,
Yeah.
Can you just elaborate on the, give your justification for the negative histories you have taken?
No history of protrusion of eye, double vision indicates that there is no optic nerve involvement or no extraocular muscle involvement. There is no history of decreased vision, suggests optic nerve involvement. No history of loss of sensation over the face suggests there is no history of trigeminal nerve involvement, branches of the trigeminal nerve. No history of loss of taste is again due to the lingual nerve, which is a branch of the trigeminal nerve. No history of decreased mouth opening indicates that there is no there is no trismus, there is no pterygoid involvement, or no history of restricted jaw movements, like there is no involvement of masseter, lateral pterygoid muscles, which are supplied by the mandibular branch. No history of ear discharge, pain or decreased hearing indicate that in a sinonasal case, if disease extends to the nasopharynx, can cause blockage of the eustachian tube, leading to pain or decreased hearing. And no history of mouth breathing and snoring is again due to the nasopharynx extension. No history of headache, vomiting, and dizziness indicate intracranial involvement.
Yeah,
No history of neck.
Kirti, may just sort of, a reduced mouth opening is very unlikely due to nerve involvement, because
The pterygoids
it's
involved.
muscle, usually the apparatus, the muscular apparatus is involved. If the nerve is involved, you would have loss of sensation over the face.
Yes, sir.
Right?
I said
So they are not
pterygoids and
motor. So which division of the maxillary would be here? It will be the V2, right?
Yes,
And
sir.
that is sensory. So when you attribute reduced mouth opening, it won't be due to nerve involvement. Rather, it would be due to direct infiltration of the muscles of mastication or involvement of the masticatory space in your case. Right?
Yes,
And
sir.
snoring again need not be obstruction of the nasopharynx. Any bilateral nasal obstruction, even a unilateral mass can push the septum to the other side and cause obstruction and snoring. So please don't commit that it's because of nasopharyngeal obstruction. It could be due to nasal obstruction as much as a nasopharyngeal obstruction. Another important point, are you done with your history? Please go on. I'll sort of interrupt you once again once you finish your history. Go ahead.
Patient had history of chewing tobacco with betel nut for past 15 years, which he quitted 2 months back. There is no history of alcohol intake. No history of TB, diabetes, hypertension, asthma, or jaundice. No history of previous surgery or known drug allergies.
Right. So you have finished your history, and one of the most important since you're jumping into a conclusion that this is a malignancy, it like the picture of the patient just shouts out to us, yes, you're dealing with a malignancy. But you heard Dr. Kesari speak that, they may even be, it must be maybe a fungal infection. So some predisposing factors like immunosuppression, use of steroids, your history of asthma is right. But if you had clarified that the patient is not taking oral steroids, probably HIV, presence with nasal mass, Kaposi sarcoma over that area. So that things that you are thinking in a more comprehensive way, and the examiner would, really give you kudos for that. That you're not just thinking of a malignancy. There could be a lot of inflammatory conditions which you could also present with a picture like that, right? Even with a short history of 4 months. Go ahead, please.
One more point. Yeah, please go ahead, Dr. Ravi. Please go ahead.
Dr. Kirti,
Yes,
you
sir.
told about the palatal ulceration. Patient had oral ulceration. So where it was actually? I mean,
it was, sir, in the palate, hard palate.
That you have not told whether it was in the palate. You told that it was in the teeth. So teeth cannot have ulceration.
No. Sir, I said that it was associated with tooth loosening. Actually, that I have included in the examination part.
But definitely in history, you could have told the oral ulceration, which part of the oral cavity was having ulceration, the palate or the soft palate.
Okay, sir.
Kirti, Dr. Hitesh here. Are we missing on the occupational history?
Sir, patient was actually housewife.
Especially in sinonasal or maxillary tumors, why is occupational history important?
Because especially woodworkers, carpenters, textile industry workers, nickel workers have a high predisposition to sinonasal cancers, and it is occupational related cancer majorly. So that is
absolutely
important.
So if the patient is a woodworker or is working in nickel chromium industries, what kind of carcinoma are you expecting in maxilla?
Sir, if in hardwood dust, we'll expect a adenocarcinoma. In softwood, we'll expect a squamous cell carcinoma.
So absolutely, it's a very important history. Good. Go on, please.
General physical examination. My patient was moderately built, ECOG 1, conscious oriented, well oriented to time, place, person. Pulse was 92 per minute, regular rhythmic. BP was 130-80 mm of mercury measured at level of heart. No pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy or pedal edema. Sorry. These are the clinical photographs of the patient. On inspection, there was irregular swelling of approximately 5 into 3 centimeter on left side of the face, extending superomedially up to the medial canthus of left eye, involving left nasal cavity medially, inferiorly extending from the left ala, involving left half of the upper lip, up to the angle of the mouth, and laterally 3 centimeter horizontally from the left ala. Also, there was a ill-defined ulceration of 2 into 1.5 centimeter present over the involved skin, just lateral to the left ala, associated with pus discharge with surrounding blackish discoloration and induration of the skin. Left periorbital edema was seen. Left nasal cavity was obstructed completely with pale reddish nasal mass, which was coming till the anterior nares, and sticky mucoid discharge were present on the nasal mass. On intraoral examination, mouth opening was adequate. On inspection, there was a fullness in left upper gingivobuccal sulcus. 4 into 2.5 centimeter ulceroproliferative growth was present in left side of the upper alveolus and hard palate, extending from the right lateral incisor to the left last upper molar, crossing midline anteriorly and posteriorly 2.5 centimeter lateral to midline. Rest of the oral cavity was within normal limits. In neck, there was no swelling visible in the neck.
You should also examine the ear also.
Yes, sir, I've done in palpation, I have done.
Okay.
On palpation, inspectory findings were confirmed. Swelling was almost the same as on inspection, except for it was tender on palpation, firm to hard in consistency, and skin over the swelling was not pinchable. On anterior rhinoscopy, there was left nasal mass completely obstructing the nasal cavity. Nasal mass was sensitive on probing, firm in consistency, and bleeds on touch. Cotton wool test was, there was decreased movement on left side, tenderness in left maxillary and ethmoid region. On nasal endoscopy, there was mass seen in left nasal cavity and no extension to nasopharynx. There was decreased smell perception on the left side, narrowing of the palpebral fissures due to edema. Finger counting at 6 meters was same on both the sides, and extraocular movements were normal. There was no nystagmus. Sensation of over the face was present, bilateral. Corneal reflex was present. Jaw movements were normal. Ear examination, bilateral tympanic membrane was intact. Tuning fork tests were within normal limits.
Doctor, are you sure about the V2 not involved? Because with this amount of skin involvement, usually the V2 is involved.
The patient had actually increased pain.
Okay.
So there was no loss of sensation over the face.
Right.
I think, Kirti, I'm reminded of my MS days when you present. And I think there must be an evolution when you're presenting as a case for an MCH. We assume that you know a lot of things, right? It's not like an MS examination, like cotton wool test and that. What if there is no airflow? Am I going to be really worried about that? Is it going to change my management? So think like an oncologist here. One thing that you wanted, the patient has dacryocystitis. You need not say that I have pressed the medial canthus and pus comes out of it. You have done your MS or you have done your MDS, you are a master, right? If you tell me dacryocystitis, I must believe you that it is there, right? That is one. Number two, this is a big tumor with the swelling in the medial part of the eye. I have a feeling it's going to the skull base. It's a good idea to sort of, complete your examination with an examination of the cranial nerves, right? So you must mention that all other cranial nerves are intact. The patient is coming to a specialist like you, right? Suppose the patient has a second primary in the larynx and you miss it. An MBBS doctor can miss it, an MS guy can miss it, but you as an MCH candidate, you shouldn't. So you must complete your examination by saying, rest of ENT, my larynx, I've done an endoscopy, I've seen the larynx, because you are a head neck surgeon, right? And so that shows that you are a complete head neck surgeon. You are able to see the person in totality, right? So if I were an examiner, I wouldn't be saying like counting of fingers and touching and feeling. You say fifth is normal means I know fifth is normal,
Okay.
right? So concise, crisp, present at the level of an MS scan. You're like a colleague. You're not an MS student standing on the other line and the examiner smirks and drinks coffee and puts marks over there. That time has changed, evolved. Go ahead. You're doing it very well.
Intraoral examination, mouth opening was adequate. There was 4 into 2.5 centimeter ulceroproliferative growth in left upper alveolus and hard palate, extending from right lateral incisor to left last upper molar. Actually, this is hanging.
So the hard palate is involved, the soft palate is free.
Yes, sir.
And the anterior part, it's crossing the midline, it's going to the other side, right?
Yes,
excellent.
Case summary: 46-year-old female presented with swelling in left cheek for 4 months, involving medial canthus for 1 month, associated with skin ulceration and epiphora. She had complaints of left nasal obstruction for 3 months, associated with nasal discharge, decreased smell sensation, and left oral ulceration for 2 months. On examination, there was irregular, firm, hard, indurated, tender swelling in left side of the cheek, involving left nasal cavity, maxilla, involving medial canthus superomedially, with skin ulceration near left nasal ala. Left nasal cavity was completely obstructed with pale reddish mass, with sticky mucoid discharge, decreased smell perception, and 4 into 2.5 centimeter ulceroproliferative growth was present in left upper alveolus. Should I continue with this cancer?
Go ahead.
Okay.
Are you okay with us interrupting you, or do you want questions at the end of it?
No, sir.
Okay, go ahead.
And this is an axial contrast enhanced computed tomography of nose and paranasal sinus, which shows that there is a soft tissue density in left nasal cavity involving the maxilla, ethmoids, and the anterior wall is eroded. And in the second line, last section, there is erosion of the posterior wall also. However, the mass does not extend into the infratemporal fossa, does not involve the pterygoids or muscles. There is a erosion of the hard upper alveolus up to the midline, we can see in the scans. And nasopharynx is free. Pterygoids are free. The coronal scans shows again a soft tissue density in the left nasal cavity involving the ethmoids. The frontal look free. In CT scan, there is no obvious erosion of the no obvious involvement of the orbit. Extraocular muscles are seen, and maxilla is involved.
What kind of window it is? It is a bony window or soft tissue window? You should also comment on.
This is a bony window, and in the sagittal scans, we can see there is involvement of the. Actually, this has shifted. There is involvement of the maxilla. The skull base is free. There is no extension to the skull base. And there is no involvement of the sphenoid sinus. It is a anterior tumor mainly. Nasopharynx is free. Prevertebral muscles are free.
Nasal bone.
Sir, just. The nasal bone, it is ipsilateral side of the nasal cavity is involved. However, there is no erosion of the septum, as we saw in the axial cuts also. This is a MRI axial scan, T1 with contrast. There is a iso-intense mass with contrast enhancement lesion seen in left nasal cavity involving ethmoids, maxilla, and there is obvious extension to the extraocular muscles involving the orbit. Nasopharynx is free, no involvement of the infratemporal fossa. Septum is.
Dr. Kirti, you cannot comment on all the extent on only axial scan.
Yes, sir.
Right? The axial scan is very good for inferior extent and the superior extent. A coronal cut is good for looking at that what is the involvement of the middle orbital wall and the other areas. You should take it in totality and then see where it is involved, and then you should comment on it. Just and I mean taking it to the next level that you can comment on all this. It is being seen, but if it is better that if you comment on T1, T2, and then T1 contrast, and then axial, coronal, and sagittal, and then you comment that in what is being seen exactly in that scan.
Dr. Kirti, I saw that you have done both investigations. You know, if you ask head neck surgeons what would you prefer for an MRI, many of the time you get an answer that we'll do both. We'll do both the CT scan and MRI. So can you tell us why did you do an MRI and how did it help you here?
Sir,
you have to be, see, whenever we talk now, we say India is a poor country and all Indians brothers. So there is a responsibility to save resources as well. But here I think you are justified in doing this. But if you can just explain it to the 60 odd speakers, why you did it, you know, it will be great. It will be very graceful of you.
Sir, in this particular case, CT and MRI both are important. They are complementary investigations. A CT scan to see the bony involvement, erosion or expansion, and MRI to see the orbit, optic nerve, muscles, the brain, the dura involvement. For all these we need, and also the soft tissue extent of the tumor as a whole, or a perineural invasion, if to see the foraminas. For all these things we need a MRI in this case, since it is an extensive tumor, not only limited to the maxilla. Had it been only limited to maxilla, we could have skipped the MRI maybe, but in this case, will
it help you to distinguish between inspissated secretions? Will it reveal the true extent of the tumor in an MRI? So as a surgeon, isn't that the most important thing that you would want? Your first question is like most paranasal sinus tumors are treated with surgery, and you're already thinking in terms of surgery, right?
Yes.
So what does a surgeon want to know? He wants to assess his enemy first, right?
Yes,
and that is where, you know, MRI stands out from the rest. It will give you tissue delineation. Orbital floor erosion scan will tell you, but if there is a gross erosion, even an MRI can tell you. An MRI can even tell you better if the orbital fat is involved, if the muscles are involved. For the orbit, it may be, as you said, I will use that cliched word called complementary. That is what you're all told in your MS days. When an examiner asks, bolo, complementary. So that is exactly what it is, and you're right. Okay. As a surgeon, what are the areas that you really want to assess in order to assess operability? Did you hear Dr. Kesari say that if you leave disease behind, you have done a grand biopsy, you have not done a surgery, right?
Yes,
so in order not to do a grand biopsy and proceed with a good surgery, you need to know where the tumor is. So what are the areas specifically, if you tell 60 of us, where exactly am I looking at? You know, where if the tumor goes, I'm not ready for surgery. So tell me, Kirti, what would you look for signs of inoperability?
So, cavernous sinus involvement, bilateral optic nerve involvement, prevertebral muscle involvement, and
prevertebral will be a long way off. If it was the larynx, I would say yes.
Extensive intracranial extension. Or
extensive intracranial extension. Would you want to stratify it further, like dural, extradural, intradural?
Intradural.
Intradural, the outcomes are really bad after surgery. It's not that you can't do it.
Yes,
you can still proceed with surgery. It's not inoperable. A frontal lobe can be taken out. But the outcomes, there is an international consortium study with over 30 participants said if it goes into the dura, the outcomes are bad, but it doesn't prevent you from doing a surgery. What else? Skull base.
Skull base. So the internal carotid artery involvement or the
perfect. Nasopharynx.
Nasopharynx involvement, clival erosion.
Excellent. So nasopharynx is a strict no. If it goes into the nasopharynx, you would not go for it. If it's a carotid invasion, you won't go. Would you go for bilateral jugular? There are no nodes here, but if there were large, big nodes, Bilateral jugular involvement, is it a strict, not a very strict contraindication?
Not a strict contraindication. We can do, if we can preserve the external jugular in that case, if possible.
You are right. Do you want to go if it's a extensive soft tissue involvement?
Extensive soft tissue involvement is a relative contraindication, but with the advent of free flaps, we can cover large areas. So that is a relative contraindication, not
infratemporal fossa.
Infratemporal fossa. So high infratemporal fossa is a relative contraindication.
In a maxilla, is it? In oral cavity, I would agree.
It
doesn't make it stage 4B.
ITF is now operable, I guess.
Make it T4B. Correct.
It is operable, but it is borderline resectable to achieve the negative margins with, depending on how much is the involvement, to achieve negative margins with surgery, whether possible or not, that can be.
So if you look at AGCC, it still doesn't make it T4B.
Yes, sir.
Yeah, because when you're operating on the maxilla, you're right there. But to go from below to up, when you're doing an oral cavity and you're going to the ITF, it's a different perspective. For maxillary sinus tumors, it doesn't contribute. It is not inoperable or doesn't constitute T4B, right? So you have pretty much covered everything, right? Thank you.
Kirti, does histology play a role in deciding your resection in some part if it is involved?
Yes, ma'am. Histology does play a role, whether we have to characterize whether it is an epithelial tumor or a non-epithelial tumor. And in undifferentiated carcinomas, generally upfront surgery is not preferred in such extensive cases. Adenoid cystic or squamous cell carcinoma, with epithelial tumors, we can surgery is the mainstay of the treatment.
So we haven't come to the histology yet, right? Kirti, I'm curious to know what is this?
Okay, yes, sir.
This is squamous cell carcinoma.
Go ahead. You present. Continue.
I have a question, Dr. Kirti. You mentioned that the patient had history of tobacco since last 15 years. So before seeing the scans, how would you differentiate whether the disease is growing from oral cavity to the sinus, or it is the sinus which is coming into the oral cavity?
Yes, sir. But since the extent of the maxilla involvement is much more than the oral cavity, and it is extending to the orbit also, so in this case, we can say that it is a maxillary, probably a maxillary origin. But
the patient
vice versa can also happen.
Symptom also before the oral symptom in your history.
Absolutely.
Yeah,
Absolutely.
Yeah.
Absolutely. Yeah. So signs and symptoms plays a very important role, as you have already mentioned in your history, that his prime concerns were about the nasal cavity. That is the reason that hints, of course, it would not say completely because of oral cavity or sinus origin, but it will hint towards sinus, because even your oral cavity cancer can go to orbit, it becomes inoperable. Yes. So they actually completely do different ball games, which will give you hints in your history only.
Very true.
Please go ahead. Thank you.
So my diagnosis after the biopsy and scans is squamous cell carcinoma, left maxilla, CT4A N0 M0.
I'm sorry, but is it M0? Did you do the CT scan?
We had done a CT scan thorax, sir. Since already we had done 2 investigations and patient was not affording for PET CT, so we had done a CT thorax in this patient.
Why would you even think of a PET CT here?
No, not in squamous cell, but in non-epithelial cancer where incidence of distant metastases are higher. In those cases, we need to go for PET scan.
This hasn't even gone to the nodes as it. It's a locally aggressive disease.
It is a locally aggressive.
Sort of pushes resources further by doing a PET scan. It's probably not justified.
So just for my knowledge, a chest X-ray and ultrasound abdomen would have been good enough. I mean, to me, if there is no other symptoms, you have already ruled out cough and other thing.
We had done a non-contrast CT thorax, sir.
Right.
Right. Okay. Good enough. So this is an M0T4A locally advanced maxillary sinus tumor. Yes.
Yeah, so you said it is clinically N0. So that is clinical radiologically N0.
Clinical
So
radiology.
what are the levels of neck have you palpated? What is the first sentinel or first node for maxillary cases? Sinus
So
maxillary.
the upper jugular and retropharyngeal.
Correct. So retropharyngeal can only be assessed with radiology. You can't put a finger into the retropharynx, right, Kirti?
Yes, sir.
Right.
So Kirti, even if it's a very extensive disease on the picture, what was the best part? What is the best good part of this disease, and what is a not so good part of this disease?
Ma'am, the good part is that it is an anterior disease. There is no posterior involvement, no skull base involvement. So this is one good thing, and the general condition of the patient was good. So these two things were good.
And the mouth opening was okay. The mouth opening was okay.
good. Yes, ma'am. There was no and no nodes, so it's just a locally advanced disease. And bad point, squamous cell is an aggressive histology. So this is one thing, and orbit extensive. There is orbital involvement that is also bad in the sense that patient will have to undergo extensive surgery.
No nodes. No nodes.
Sorry, ma'am.
There is also some quite extensive skin and soft tissue involvement. Skin involvement. Yeah. So, in a maxillary cancer, what are the prognostic factors you feel these are the good signs? These are good prognostic factors.
Ma'am, histology of the tumor, orbital involvement is a bad prognostic sign. Lymph nodes involvement are bad prognostic features, and
tumor differentiations.
Grade of tumor differentiation.
Orbital extension does not confer bad prognosis. It is mutilating. It's mutilating. Survival doesn't fall. The survival, see, the more posterior you go, survival drops. Orbit, we are worried because it's a vital organ, right? And it's close to your heart. If you tell a patient, have you seen their reaction when you tell them, it's morbid, right? But skull base, infratemporal fossa, where you are operating in closed spaces, mostly getting margins around that at the skull base is a challenge in such large extent. Nodes are a bad prognostic indicator, right?
And sir, skull base, the central skull base is more problematic if it is involving the central skull base, especially the spinal and clivus.
Correct. More posterior.
Here you may respect the bone and maybe a part of dura.
Correct.
Less than 5 millimeter, but posteriorly it's impossible to get a mark.
So now we're curious to know again, Kirti, what did you do with this patient?
So we did a total maxillectomy with ethmoidectomy with
extended maxillectomy.
Sir?
The word would be extended maxillectomy.
Extended maxillectomy, yes, with orbital exenteration.
Orbital, you said the orbit is not involved and then you went on to take out the orbit?
Yes, sir. Extraocular muscles are involved in MRI.
That is orbital extension. Is it?
Yes, sir.
The muscles are involved, so it's involving. I missed that on the scan. Maybe you're right. Carry on.
It was not very evident on the CT, but
this part of the.
I would look at it on a coronal cut. That is when you see all the recti muscles. If it's still in the, many a times you take a surgical decision. If you can take it off the periosteum, you don't need a centimeter margin there.
Yes, sir. Yes, sir.
Yeah.
If we see during intraop that there is just a limited periosteal and periorbital involvement, or we can send a orbital FAT for frozen. If it is negative, then we need not do orbital exenteration. But in this, we needed to counsel the patient for orbital exenteration. And however, when the patient was operated, there was extraocular muscles involved, and so we went ahead with orbital exenteration.
Dr. Kirti, T2 images of MRI always overestimates the disease. So is there any way in which because this is a very sensitive matter, the disease is just reaching the periorbital fat, is there any way you'll be able to merge two images like STIR, T1, T2 and discuss with radiologists to find out whether actually the extraorbital content is involved or not?
Yes, sir. In cases of doubt, since the patient in history does not have, and also examination does not have any eye symptoms except for the epiphora. So this was, but on the MRI when we saw, we had discussed with the radiologist and even it correlated intra-op in this particular case.
There are some sequence like fat set.
Absolutely.
Yes, that. Yes, sir.
STIR images and fat.
Yes.
Yeah, so that's why I said, MRI is probably a great tool for a maxillary sinus tumor. So the radiologist can actually use gadolinium to look for enhancement of tumor. And they use a sequence called it's called diffusion weighting. So diffusion weighted sequences, usually tumors would there's a restriction of gadolinium going into that. And that's a good way of delineating whether but again, at the end of it, it's the involvement of the orbital periosteum at the time of surgery that will probably guide you. If it is free, there is no role for taking out the orbit in these patients.
Even in limited periosteum.
I have been emphasizing so much on preserving the orbit. So, Kirti, anything that you know of whereby people have tried to preserve the orbit? Any other strategies to preserve the orbit?
Yes, sir. There are a couple of studies where show that neoadjuvant chemotherapy, even in stage 3 and 4 maxillary squamous cell cancers, have played a great role in first prognosticating the patient. Those who have partial response, even a partial response to neoadjuvant chemotherapy, have a better prognosis. And in around 70 to 80% of the cases, they could preserve the orbit. So there was a study by Hanna et al. In 2011 and again by Hanna et al. In 2021. Also, there was a study by the Tata group. It was in unresectable squamous cell cancers.
No, I was talking about orbit preservation.
It was not of the orbit preservation with the endpoint, but when they saw...
Kirti, so please focus on the question, right? So like if you're asked to talk about a cow, you say, I'm going to tie the cow with the rope and then you go on describing about the rope. Nahi. That would put you in a bad light. Here the question was on orbit preservation using non-surgery, like larynx we have. You're very well aware of the RTOG 9111 studies and all that. But are you aware of any study where the orbit is you're trying to preserve the orbit using, say, NACT? You just mentioned NACT. Are you aware that people are trying? Because, you must be curious here. Is there any way I can save the eye? Have you ever gone into literature and seen if there are any studies?
Yes.
There are. Okay, so there are studies and it has been going on for a long time. This is just for your information. You can go and dig out the papers. I'm doing it spontaneously. So maybe I don't have all literature at hand right now. But 93, even the 90s, people like Gary Clayman, Helmut Gephardt, they tried to give induction chemotherapy and reduce the tumor, move it away from the orbit, but the problem is to get a functional eye after NACT procedures. It was very rare to get a functional eye. Later, 2002-3, from Denver, there was a group with 60 patients treated with NACT. They found that 40% of their patients did not have a functional eye. So even if you preserve the eye, you would be required to radiate that eyelid, right? So what happens if you radiate the eye?
So it can result in painful eye, which is a...
Absolutely. Cataracts are better. You can put in a glass lens there, but a painful red eye is a dangerous sequelae. It's a painful sequelae. And second would be diplopia. You may remove the orbital floor, and if your reconstruction isn't good, your two eyes would be at 2 levels. And diplopia is a disabling condition. The patient would come and say, I would rather keep my eye closed or patched to see with the other eye. So that is why probably. And so 10% of them lost their eye. In that study was by Imoli from Denver. Okay, so nobody really enjoyed doing that. So that is why we are stuck there with NSCT. It's a very sensitive issue, isn't it? Preserving the eye.
Yes.
So go ahead. Don't just take out the eye at the drop of a hat.
Yes.
Right.
It is very good. I mean, psychologically, it's a very, denting for the patient to remove an eye, and if we can give one or two cycle of NSCT, it's maybe worth it.
The author is Imola from Denver. Yes. From Denver. Yeah. Go ahead. Go ahead, please.
But sir, even if you preserve the eye, at least the patient will have the cosmesis. Even if it is not functioning, the patient, rather than having an ugly cosmetic deformity of losing the eye, if we are able to preserve the eye, even if it is not functional, I think that is like the patient will definitely agree with at least you preserve the eye. I agree,
Dr. Meher. Yeah, but for the globe, I think, there is a big role for prosthetics here.
Right.
Nowadays, you can really good centers can make eyes which compare the colors, map the color from the other eye. They can do a pretty good job.
That is definitely true, but that is very costly affair. Like
Correct.
What we have patients like in Mucor, we almost removed 40 patients with Mucor having orbital involvement. We removed the eye, but not more than 2 patients could afford the prosthetic eye. Rest all of them are actually without.
Yeah, good point.
That is the thing.
So any pictures of your surgery, like what you have done? How did you reconstruct, or did you need reconstruction?
Sir, I have not put up the pictures actually, but we reconstructed with a free anterolateral thigh flap.
So if you look, what were the goals of your reconstruction here?
The goals of reconstruction are oronasal separation. Then we have to cover the eye. The general goals of reconstruction are dentition, oronasal separation, orbital support, then a cosmetic bulk of the cheek.
She's a 46-year-old lady.
Yes, sir.
So would a single flap with an ALT, do you think, suppose you had the expertise, you had like 5 plastic surgeons working under Dr. Kirti Khandelwal, all brilliant microvascular surgeons. So what would you instruct them? What do you want from them?
Sir, we would have in that case gone for at least a dental rehab with a bone.
Yeah, because
composite flap would have been done. Maybe a iliac crest with oblique muscle or a thoracodorsal artery flap, angular artery flap. So we would have reconstructed the dentition part, and also if we have too much expertise, then we can make a space for the globe so that the prosthetic eye also fits well. So
lip. It's important that the lip is also a functional unit, not just cosmetic. And here I see that if you take a margin on the tumor, half of the left upper lip goes as well, right? So ideally, you would need a combination of flaps here, probably staged surgery. Being an advanced disease, you may not want to reconstruct everything in one go, but leave the sort of foundation there for future reconstructive surgeries. Maybe she will do well. It's only a locally advanced tumor. It's not going to the pterygopalatine fossa. It's not going intracranially. It's not going nasopharynx. There are no nodes. She may do well. So I think, it's incumbent on everyone to get the patient back to her life. And
my question is that, from your expertise, would you like to give NSCT to this patient to try saving the eye, sir? Or would you straightway go for this particular case?
Since there is no evidence as of date today that NSCT works, and we don't have experience of NSCT in trying to preserve that, I would stick to protocol. And if the orbit periosteum is indeed involved, we would take out the eye here as well. But these are thoughts. When you're thinking as a group, I think these are interesting areas where we can sort of venture out.
Another point of view is that even if you give neoadjuvant chemotherapy, there will be 30 to 40% who will progress on chemotherapy.
Perfectly fine. You're right.
So in that scenario, In that scenario, your borderline disease will become inoperable.
But it has to be done under surveillance, under supervision. That goes for any kind of NACT, not just for the orbit.
Dr. Kirti, another question. We are talking about reconstruction. Before that, did we address the neck for this case? And if
yes, great
then
question.
What is an extent of neck dissection?
Sir, we had done a selective neck dissection, although in N0, NCCN does not recommend a neck dissection. Elective neck irradiation is done. But since a tumor was going to the oral cavity, and it was involving half of the palate on the same side, we had done a selective neck dissection for this case.
Rather, I would differ from Dr. Kirti here because the big area, the skin is involved here. Skin is rich in lymphatics, plenty of dermal lymphatics there. So having crossed the midline on that side, even on the palate you have crossed the midline, I would prefer a bilateral neck dissection.
We had sent level 1A for frozen. That was negative, so we did not do
What is the lymphatic drainage of maxilla in that case?
Sir?
If you say you have sent a 1A for frozen and based on that, you are basing that you're not be doing neck dissection on the right side. What is the lymphatic drainage of? There are two pathways of lymphatic drainage for sinus.
There are from the nasal root and either the first echelon node is the second upper deep cervical node, and the retropharyngeal.
So what is the pathway? So one pathway will go through retropharyngeal to level 2, that is jugular-digastric, and second pathway will go from your palate to submandibular gland. So your 96% of your nodes will be in 1B and 2. So if sir is saying disease is crossing the midline, that means it is involving the another part of gingiva. That means it might go through the retropharynx or it will go through submandibular gland. If it is going through submandibular buccal nodes, then your 1A will come into action. But if it is going through retropharynx, then your 1A might not be the central node where you will, which will indicate that the nodes is crossing on the other side of the neck.
But like in this case, since it was a ipsilateral maxilla involvement, ipsilateral nasal cavity involvement, so and the oral cavity with a midline, just a midline extension, so more preferred pathway could have been an oral route. So that is why we had sent 1A.
So you have the histopathology of this?
It was consistent with the squamous cell.
N0?
It was N0, yes.
So do you know about the randomized control trial about where non-squamous histology or squamous histology, where the two groups where the neck dissection was done, and then in another group where neck dissection was not done? Randomized control trial done by Abu et al.
In sinonasal cancer, sir?
Yeah, maxillary sinus. Yeah.
I know of MSKCC study where there were 927 patients, but it was a retrospective study where they saw that in advanced sinonasal cancers, there was a benefit of elective neck dissection in adjunct to the elective neck irradiation also in more than T3 tumors, more than 4 centimeter tumors. That had an impact on the disease control, not the overall survival was not documented.
So that is the basis of NCCN guidelines. So NCCN guidelines says elective neck irradiation is an advanced disease. Very important point, correctly said, that it may not impact overall survival, but it impacts the regional recurrences. So regional recurrences almost reduced by half, and more importantly, even if the salvage is to be done, the salvage was able to be done in 58% of the cases in which the patient who received irradiation, while those who do not receive irradiation, only 34% could be salvaged. Please go on, please.
Kirti, as Hitesh had once mentioned, in NACT, especially in squamous cell carcinoma, we do not know it's very unpredictable, the response to NACT. So if it is an upfront resectable, then it's always better to go ahead with an upfront resectable and do not give NACT. But what are the histologies per se in a sinonasal tumors which actually responds to NACT, and we usually give NACT in those cases? Squamous cell, we know it's not we do not have robust evidence on the response of NACT to squamous, but what are the other histologies, non-squamous, which actually responds to
neuroblastoma, undifferentiated, sinonasal undifferentiated carcinomas.
Sinonasal undifferentiated carcinomas, NACT works. It's also not very evident. CTRT works. NACT in some cases they have seen, in some cases, so it's not very evident NACT will work in SNUC. This esthesio, yes, but esthesio, do you have any grading of esthesio which says ki, it works more in this group and not in that group? You have any grading of esthesio?
Young's grading is used for esthesio neuroblastoma, grade 1, A, B, C, D. D is a Morita classification. A
so that is clinical. I'm saying about pathological HIMS, which will decide on your NACT, which will tell you if this group of NACT, this group of pathological grading will, you have to give NACT, and this group will not.
P53.
You know any pathological grading for esthesio?
No, ma'am.
So there is the HIMS grading. HIMS grading. So HIMS grade 3 and 4 has got a very high incidence of distal mets. So usually we go ahead with NACT in 3 and 4 because the rate of distal mets are more. In HIMS 1 and 2 considered to be a bit low aggressive in histology aggressiveness. So that's why we can go do without NACT. But yes, we decide on NACT on esthesio depending on both the HIMS as well as the Kaddish-Morita classification. Yeah, and anything more? I mean, any more histologies where NACT works?
Mucosal melanomas?
No, mucosal melanomas do not work NACT anymore. You have the neuroendocrine carcinomas. You have the sinonasal neuroendocrine carcinomas, not the undifferentiated carcinomas, but the neuroendocrine carcinomas. You have the small cell carcinomas. Any more, you know?
Rhabdo also works. Rhabdomyosarcoma.
Yes. Rhabdo NACT is actually the first line of modality, especially in kids, RMS, right? And there is also a paper by Lisa Lisitra where they have seen the genomic sequencing of adenocarcinomas. And do you know anything about that paper?
Ma'am, in that they showed that P53 and P53 positive tumors had better response to NACT than.
Is there any division of that P53 which works better and which will not work with NACT?
Wild type P53.
Yes, functional or wild type of P53 works with NACT, and the mutant P53 do not respond so much with NACT. Yeah. Okay.
Kirti, what are differential diagnoses you can think of before doing a biopsy in this case?
Sir, since it is a short history, my differentials will include mostly malignant ones, can be squamous cell, adenocarcinoma, adenoid cystic carcinoma, or undifferentiated carcinoma.
So just
fungal sinusitis, it will include only malignant ones.
Okay, so just imagine this patient you saw a week back, and she was absolutely all right, and in a week's time you see such destruction happening in mid-nasal and maxillary area. What kind of disease you can think of?
Midline NK T-cell lymphomas.
Absolutely.
The spectrum is huge, the kind of histology that you would get in it. That is why we don't have protocols for many of these treatments, because some of them are so rare, right? Most series on esthesioblastomas would be like 10, 20, 30, not more than that. They're like salivary gland tumors, and they're all clumped together, and we form protocols based on that, even salivary gland origin.
Yes.
Right? So that is what limits us from making protocols in maxillary sinus tumors. So is that okay? Shall we conclude? Did you give adjuvant to this patient?
Yes, sir. We gave adjuvant RT.
Right. So again, right. Fine.
So RT was given bilaterally or again to single side?
Sir, elective neck radiation was given bilaterally and maxilla to the ipsilateral side.
Dr. Kirti, how did you reconstruct?
Sir, we reconstructed with the anterolateral thigh flap.
And what about the palate?
Palate, we had given a ALT flap only. Their dentition part was not there, but the oronasal separation was there.
Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.
Thank you, Dr. Asim. Can we conclude?
Thank you so much.
Right.
Thank you, sir, for this wonderful session. Since recently, since 2018 onwards, there have been several studies that have come on the maxillary sinus tumors. Specifically, a lot of series from the MD Anderson and MSKCC group, and also a few series from Tata hospitals in India, where we have studied about the role of the neoadjuvant chemotherapies, the workup and the management. And therefore, it is essential for everybody to please go through those, specifically the people who will be appearing for the examinations. I would like to request Dr. Arun if you would like to make any comment about the presentation of Kirti and how each of the examiners and also the other examiners and how each of them are going to grade.
Yeah, so Kirti, you have done a great job. I must admit, you have gone through the case very well. You know about the case. That is the most important thing that an examiner will seek out. The second is, whenever you're going for an MCH, whenever you don't learn from books at this point of time, your textbook days are over. You must refer journals you must be curious about the case, all aspects of it. The surgery, the reconstruction, whether you need adjuvant or not, like orbit preservation, right? And so that is where you would stand out. And please keep referring. Nowadays, I think in the age of internet, you don't have to go to a library to find out recent literature and articles. So that should be your learning material. That should be your, like Dr. Asim just said, a lot of papers have come out. Maybe it's happening at such a pace that we also miss out on a lot of current literature. So please make it a point. This is the best time to pick up on those. The presentation was quite comprehensive and you did quite well. And if you ask me, like, what did you ask me, Asim, would I pass her? Is it? She's
definitely going to pass. We don't have any doubts about that. So any comments about her improvement, that will be best, but definitely she's going to pass.
Yeah, so that is why, Kirti, I think you should keep current literature in hand. Whenever you are preparing for an area, just go through, keep a compilation with you of all important literature that comes you. I'm sure with these programs that we have, time and again, people will be referring to various literature. Just jot it down, go back home and refer to them. And that would put you in great standing. So well done. And
thank you, sir. Thank you. Dr. Ravi.
And thanks, Asim. Thanks to you for such a lovely
Dr. Asim, Dr. Kirti did very well. She presented the case very well, and she could answer all the questions of all the panelists. And I think she did a wonderful job. Thank you.
Thank you.
Dr. Amit, anything specific you would like to add upon to? Thank you, Kirti, for the presentation. And thank you, Dr. Amit, for the wonderful talk. And I thank you all for joining us today. Next, we will be meeting on 21st of April, and the topic will be on the oropharyngeal carcinomas. And the presentation is going to be by Dr. Sarvani Ghosh Lashkar. She's a radiation oncologist at Tata Memorial Hospital, Mumbai. See you on 21st. Thank you, everyone. Thank you so much.